Hello everyone, my name is Dr. Saras Lad. I am a full-time pediatrician and today we will discuss a few points regarding nutrition in children with congenital heart diseases. We will discuss it under the following headings: differences in the nutritional demands of children with congenital heart diseases, pre-op stabilization, nutritional stabilization in children, post-operative management, nutritional management, and some special scenarios like congenital congestive cardiac failure in congenital heart diseases and single ventricle diseases and Fontan diet. So first we will discuss how the nutritional requirement of children with CHDs is different. Firstly, there is a higher energy demand due to an increased cardiac oxygen demand and energy demands. Also, there are poor energy reserves and energy stores due to the long-standing energy demands, long-standing high energy demands. There are also some underlying infections, sepsis, which increase this energy demand further. Thus, congenital heart diseases are important causes of acute and chronic malnutrition in infants. There is also increased protein requirement because of the net catabolic state which lasts for a chronic period. Also, there is an increased demand in iron because of the increased erythropoiesis in case of cyanotic congenital heart diseases. Now, we will discuss about the pre-op nutritional management. For the pre-op time, we give energy-dense food, energy-dense nutritious food or RUTF, ready-to-use therapeutic food. This increased energy foods can help up in the catching up and the increased demands of energy demands of the child, and it can also help in increasing the energy reserve for the child who is supposed to go for a surgery. There is also significant changes in the nutritional demand immediately after the post-op period, because the cardiac surgery causes a significant stress effect on an already nutritionally deficient patient. Additional energy demand and protein demands are required to ensure a net positive nitrogen balance and ensure an anabolic state. Around 120 to 150 kilocalorie per kg per day are required to meet these demands. Now, these demands are to be met either via an enteral route or the parenteral route. We will first discuss about the enteral route. Enteral route is preferred as it allows a complete nutritional support without any significant complications. It is delivered through orogastric tubes or via orally. Judicious protocols regarding the enteral feeding in specific instances such as Fontans have to be done. Coact repair has a complication such as mesenteric arteritis. Norwood procedure has a significantly decreased gut perfusion and ischemia. Now, other challenges are some complications like poor sucking and oromotor reflexes in the neonates, deranged anatomy due to associated defects such as cleft palate, cleft lips, etc. Poor splanchnic circulation leading to poor absorption and assimilation of the nutrients, and associated complications like necrotizing enterocolitis in case of neonates. Post-operatively, parenteral nutrition can also be given, for which the indications are post-operative ileus, gut ischemia, and malabsorption. The parenteral nutrition is composed mainly of amino acids, glucose, intralipids, trace minerals, and vitamins. Proteins. The proteins are provided in the form of crystalline amino acid solutions. During stress or catabolic illness, there is a high nitrogen loss. Around 1 gram of nitrogen, which amounts to around 6.25 grams of protein, which is equals to around 30 grams of net muscle mass, which can approximate to around 25 to 30 grams of protein loss per day during an acute phase. Hence, increased amounts of proteins are needed in critically ill patients for efficient utilization, and the ideal ratio for the non-protein calories and grams of nitrogen is 150 is to 200, 150 is to 1 to 200 is to 1. Energy demands are provided for the basal needs and for the growth. In catabolic states, the need may be twice as much as the basal needs, which is around 130 to 150 kilocalories per kg per day in sick neonates. Fats are provided via 20% intralipid, which is a safe and concentrated energy source. Infusions must be gradually increased. They are started at the rate of 0.5 to 1 grams per kg per day and increased by 0.5 grams per kg per day, and they are maximally increased up to 4 grams per kg per day. Ideally approaching to the 30 to 40% of the total calories. Carbohydrates are provided via glucose infusion. Initially, the glucose infusion rates are kept at 4 to 6 milligrams per kg per minute and increased over a few days to 8 to 10 milligrams per kg per minute. When a glucose concentration requirement is more than 12.5%, they are delivered through a central vein. Now we will discuss some specific cases like a child with congestive cardiac failure. Fluid restriction has to be done. Fluid has to be given judiciously so as to not increase the preload, which is around 2/3 of the maintenance fluid, which usually amounts to the previous day's losses as well as insensible losses. Calorie requirements, 10 to 30% of the additional calories are required, which have to be additionally given. Proteins, the requirement is calculated as per the age, and 10 to 30% of the total calories are to be provided by high biological value proteins such as eggs. Fontan diet. There is high requirement of protein after a Fontan surgery, which has to be met by around 1.5 grams per kg per day to ensure a proper nutritional growth, and the fats have to be given in form of medium chain triglycerides, which are easily absorbed through the mucosa bypassing the portal circulation. Thank you.